What's going on, man? Señor, ¿qué pasó? What up, what up, what up? What's going on, guys? Coming a little late for Case of the Day explanation live, but that's all right. Good evening to you. Brother, what's up? I just had my omelet, asparagus, all that good stuff right now. 6-chapter pathology test. Come on, that's crazy. That's too much. Love this page. Appreciate it. Really, really appreciate it. Page is nothing without you guys. Seriously. 6 chapters, man. What do they even test you on? That's too much. That's too crazy. So what did I do today? What kind of procedures? Let's give you guys an idea of what kind of caseload I have during the day. I had, God, I don't know, 5 portacath placements. It was just port day today. I think I placed 4 or 5, something like that. I don't know what it was. 1 port removal has been in there for a couple of years. 2 nephrostomy tube placements. A chest tube. And I think that was it. Maybe some biopsy. I don't remember. That's kind of a caseload for today as far as procedures wise. Nothing like big cases. It was a lot of the routine bread and butter IR stuff. But hey, it's always fun. Seriously, it's always fun. I had to get myself out of a jam for a port placement today. You'd think it would be, every case would be easy. No, there's always some sort of something that makes you think on the spot. Makes you, redo things that you usually don't do, and it's just fun. I love IR. Obviously, that's why I posted that post today. How long are your shifts? I don't know. I got in today at 7 a.m., and then I left at 6:30 p.m., something like that. That's kind of a typical day for IR. Test covers hematopoietic, endocrine, reproduction, 3 branches of trauma. That is a lot. That is a lot of stuff to be tested on. 3 branches of trauma. Jeez. Anyway, you guys take a look at Case of the Day today. I'm kind of going to keep up this format. I'll try to post everything, all the different types of questions in the morning, early morning, or whatever time of the day it is for you guys. Maybe evening-ish if you're on the other side of the world. And then we'll do this, hours and hours later, and we'll kind of just go over it. So let's pull up the image. Where is it? There we go. All right, so we got the image up, and this was what I posted. All right, what do you guys see? What do you guys see? Am I happy doing what I do? Absolutely. Every single day I come home and I'm like, yes, I absolutely love my job. I can't see myself doing anything different. And that's why I like sharing the love for you guys and giving you guys these posts where I title it, "You Are Now the Interventional Radiologist." I want to put you guys in the driver's seat and see, hey, firsthand, what would you do? All right, so we got Case of the Day. This is what I had posted earlier today. We're going to break it down just like I do every single time. Let's go from the very, very beginning. This is a cross-sectional or an axial cut of the abdomen. It is a contrast-enhanced CT scan, all right? And we're looking, basically, what are we looking at? We see 2 kidneys, right? So, all right, we see some kidneys. Cool. We see some liver. We see the right hepatic lobe is the big area kind of to the right of the patient. And then the left hepatic lobe is kind of midline-ish. And you notice that there's some junk in there, right? There's some weird hypoattenuating material. Remember, CT verbiage, hypoattenuating. Attenuating is one, or you can use density. So there's some low density material or some hypoattenuating material in the liver. All right, so without really going too much into that, just because you have to kind of scroll in and out to see exactly what's going on with the liver, but there were some abscesses in the liver. There's some weird perfusion abnormality as well in the liver. So I didn't want to focus too much on that. But what I did want to focus on is what is the big structure in the right hepatic lobe that's kind of rounded. You see what I'm saying? Let me get my water. A little sparkling water, Trader Joe's. What's that rounded structure sitting right above the right kidney, basically kind of in the liver area? You guys see what I'm talking about? Yeah, it's the gallbladder. So that is the gallbladder. Yes, and the question is why does it have an air fluid level in it? That's weird. Not only does it have an air fluid level in it, also, if you look at the rim of it, the wall, why is there air within the wall? And then you may ask me, yo, how do you even know this is air? Because like I always say, use your internal controls. First of all, you correctly pointed out that there's an air fluid level. So then you know that that dark area is air, right? So then why is there that same density around the wall of the gallbladder as well? So now you have to figure that part out. You're like, wait a second. Why is there air in the gallbladder? It's like layering in there. There's an air fluid level, but then there's also air in the wall of the gallbladder as well. So a couple of different things. Some people got it right. Some people went down the route of something that's fancy, which I like. Let's talk about the thing that it's not. A lot of people did mention a fistula or gallstone ileus or fistulization with the duodenum. That is a great, absolutely great thought. Had I shown you dilated small bowel loops, yeah, definitely you can start thinking about gallstone ileus. Anybody know what gallstone ileus is? For the sake of time, I'm just going to go through it real quick. There's basically the huge stone in the gallbladder has eroded through the gallbladder, and it popped into the duodenum, it fistulized with it, and then the stone goes distal, and it gets stuck somewhere, usually in the terminal ileum, and then it causes an ileus, basically because there's a blockage, so nothing can go past the terminal ileum. That's what a gallstone ileus is, but this is not what it is, all right? A lot of people, again, mention a fistula. So you can have pneumobilia. And what is pneumobilia? We've talked about this before. Pneumobilia is air within the gallbladder or the biliary system. So yes, there is pneumobilia here. Absolutely. Okay, so we know that. But the main thing that I want you guys to focus on is why is there air within the wall? Okay, that's always the concerning thing. Why can somebody have air within the gallbladder causing an air fluid level and it not being a bad entity? That can happen with somebody who had a sphincterotomy, if somebody had an ERCP done, right? Endoscopic. So if somebody has an ERCP done and then they did a sphincterotomy, they basically went down to the major papilla and they opened it up because maybe somebody had some choledocholithiasis, something was going on. So they just burned open that papilla or the sphincter, and basically now you have an open channel of, so if this is the duodenum right here and the CBD comes in like this, now you have an open channel between the air in this duodenum and in the CBD. So that air can reflux back into the gallbladder. That's one way that it can happen. So this is another way that it can happen, and this is a bad way. That way that I just described, not so bad. This way that I'm about to describe, bad, all right? Anytime you have air within the wall of a organ, say if you have air within the wall of bowel, you guys may know what that's called, pneumatosis intestinalis, right? If you think about that, then you're thinking about something kind of scary, maybe some bowel ischemia. So this is air within the gallbladder wall. So this is actually called emphysematous cholecystitis, all right? So there's air in there. Emphysematous meaning air, emphysema, you've heard about that in the lungs, so that's emphysematous, and then cholecystitis. So you can also have emphysematous pyelonephritis, you can have emphysematous cystitis, which is the bladder, all right? So you can have emphysema or abnormal air within the wall of different types of organs, all right? So this specifically is emphysematous cholecystitis. So this is actually a surgical emergency. So not only, let's just talk about real quick what cholecystitis is. Usually cholecystitis is calculus, meaning that there is some sort of gallstone causing occlusion at the neck of the gallbladder, and basically the gallbladder can't drain properly out. And if it can't drain properly, and where does it drain, right? It goes through the cystic duct, and then which that connects into the CBD, and then the CBD will go into the duodenum, and then the bile will go out into the duodenum, into the bowel like it normally does. Say if there's some sort of occlusion, meaning a stone stuck in the neck of the gallbladder, or if there's a stone in the cystic ducts, wherever it may be, that can cause back pressure built up into the gallbladder. Nothing's draining as it should. And then bacteria can get into there, and then it can cause some really bad stuff, right? So that's cholecystitis. So now emphysematous cholecystitis is basically when you have certain types of bacteria. Clostridium's one, and then E. coli is another one. Those are the two big ones that you really think about when you think about emphysematous cholecystitis. Does anybody know the systemic disease that is associated with emphysematous cholecystitis? I'll give you guys a couple of seconds. Usually, I don't know what just happened there. It said poor connection. Anyway, I'm back. All right. Usually cholesterol-based stones. Yeah. Anybody know the entity, the disease process, the underlying systemic disease process that is commonly seen with emphysematous cholecystitis? Couple of seconds. Try to shout it out. I broke up at Clostridium. Yeah, so usually Clostridium and E. coli are the two main bacteria that are associated with emphysematous cholecystitis. And what I was alluding to before is diabetes. Diabetic patients are prone to getting emphysematous cholecystitis. They may not be prone to it, but at least I should say emphysematous cholecystitis is commonly associated with diabetes. How about, let's put it that way, right? So, and then usually when you think about just regular cholecystitis, you're usually thinking about a woman. It's more commonly seen in women. Gallstones, remember the 4Fs, whatever, right? Female fat, 40, what am I missing? Something else. One more thing, right? And then this emphysematous cholecystitis is kind of reverse. It's actually usually seen in men. And again, I've mentioned that it's diabetic patients. And again, it's E. coli, Clostridium are the two main ones. There you go. 40 female fat fertile. There it was. Thank you. So those are the main things that you want to think about for emphysematous cholecystitis. Again, this is a surgical emergency because you see air within the wall of the gallbladder. This can cause perforation and necrosis of the gallbladder wall. Go consult surgery. They may need to take it out. If the patient is a poor surgical candidate, then yes, IR, we can put a cholecystostomy tube in it, absolutely. If you've ever seen a cholecystostomy tube being placed, by the way, we like to, and this is a common misconception, and surgeons have freaked out about this when they've seen our imaging, we like to place the tube through normal liver and then into the gallbladder, all right? The theory is that it decreases the rate of gallbladder leak or biliary leak. Afterwards, the bile is just going to kind of leak into the liver and it'll kind of take care of itself and it won't leak into the peritoneum if that were to happen, all right? So we do like to place our tubes through normal liver and then into the gallbladder, all right? We don't actually... Rarely, I mean, we definitely can place the tube just directly into the gallbladder. It's based upon anatomy. If it's easy to go directly into the gallbladder, sure. Sometimes with these chronic cholecystitis patients, the gallbladder wall is very, very thick. So when you get your needle in there, it actually just bounces off the gallbladder and the gallbladder just keeps flopping away. So that can be kind of tough sometimes. Through liver parenchyma. We will place the tube through the liver parenchyma and then into the gallbladder. What were the patient's complaints for this study? Basically the same thing as cholecystitis. Right upper quadrant pain, that kind of stuff. They're going to be feeling the same kind of stuff. Nausea, vomiting, fevers, chills, all that good stuff. Right upper quadrant, pain, all that. What else, guys? Any questions? Let's turn this off. Let's go this. Let's go this. Let's do that. Does body habits come into play for tube placement? Yeah, body habits can be tough because we use different imaging modalities to place gallbladder or cholecystostomy tubes. We can place them with ultrasound, which we absolutely love doing because it's real time. Spatial resolution is it's awesome in ultrasound. we love placing it with ultrasound. If the patient's too fat, there can be a lot of subcute tissue underneath that may be tough to see the gallbladder. Then we may opt to go to CT. It's all variable. If we place it with ultrasound, we will place the tube with ultrasound into the gallbladder. We'll curl the wire into the gallbladder, and then we'll use fluoroscopy right after it. And then it will show us all the X-ray portion of the procedure. Any referred shoulder pain? Sure, that's a great question. The reason one Krabby's asking about shoulder pain is because if anything's tickling the diaphragm, or if anything is causing irritation to the hemidiaphragm on whatever side it is, it can cause referred shoulder pain to that ipsilateral side. In this case, I'm not sure if the patient had it or not. Is the hyperdense content sludge in the gallbladder? The hyperdense content is actually just regular old bile. It looks more dense, or you want to call it more dense, because the air next to it, that air fluid level, is very, very dark. So it makes you want to say that the layering bile is just more, it's bad. It was just bile. A lot of times when we place tubes in these acute cholecystitis patients, just bile comes out. It's not like frank pus that you would think about every single time. Yeah, obviously sometimes it is very purulent material that comes out, but sometimes it's just bile. Any other questions I can answer for you guys about case of the day? HIDA ultrasound might show stone sludge. Yeah, let's do an ultrasound for that. HIDA will tell you if it's acute cholecystitis, if there's a chronic component, if there's an ejection fraction component, and then ultrasound will show you stones and sludge. It's a very high resolution with ultrasound. I am UMC, University Medical Center. I am. Where are you? Absolutely. Enjoy teaching. You guys ask any questions always. That's what I'm here for. Hello, wave. All right. Any other questions I can answer for you guys, or should we call it? And then you know the drill. I'll get you guys case of the day tomorrow morning. And I don't know. I kind of think of it on the spot as I'm doing my cardio. Any recommended or questions, suggestions, recommendations? I guess I could say for what kind of case of the day you guys want. Just message me, let me know, and then go check out my post from earlier today. See what an interventional radiologist can do for a bleed. More GI. All right. All right. San Hughes. Where's San Hughes? All right, guys. Case of the day. Ha! My mom's waving at me. All right, guys. I will catch you later, and we will pick up on this tomorrow. Good night. Later.